It's a particular pleasure for me to introduce our next speaker. Dr. Michael Gelb is a recognized authority and author, speaker on TMJ, sleep apnea, sleep disorders, and chronic headache chronic headache treatments, rather. After graduating from Columbia University with a DDS degree, Michael received his MS degree at SUNY Buffalo in neuromuscular research. Dr. Gelb went on to become clinical professor at NYU, where he directed the TMJ and orofacial pain program. Dr. Gelb provides solutions for dentists to incorporate the specialty of airway and sleep issues into their practices. He is also the co-founder of the Foundation of Airway Health and its Airway Summit. He is also the co-author of GASP, along with Howie Hendon, a member of this academy. GASP is the Airway Health, the Hidden Pain to Wellness, a recent book which I've read and I highly recommend. He recently developed the ACG day-night appliance system and has invented a number of other devices and appliances for treatment of sleep disorders. He has also pioneered the Airway Centric medical and dental education and maintains a private practice in New York City and White Plains. I heard Michael speak several months ago at a sleep apnea conference that I attended, and we hadn't run into each other in about 20 years. But if the name Gelb is familiar to many of you, then you may know of Harold Gelb, his father. Harold Gelb was my mentor in dentistry, and I wanted to acknowledge him because if it weren't for meeting Harold in about 1976, 77, something like that, I probably would have been out of dentistry decades ago. So it's particularly enjoyable for me to bring his son on. And Michael has forged his own path based on some of the work that Harold had done, but in a whole different area of airway-centric dentistry. So please give a warm Academy welcome to Dr. Michael Gelb.
Thanks. Richard, thank you very much. It's really a pleasure to be here, and I'm so impressed with what I heard this morning and being in the exhibit hall. You guys are wonderful. I think that what you're going to see is that when we add oxygen and we add refreshing sleep into the mix, everything you do probably works better. And so we are pretty much complementary to each other. And I've come in my own path. You know, my dad was ahead of his time, and he was bringing the jaw down and forward into what they call the Gelb 4-7, which I think you can still get into a lot of trouble to today in certain states, and in Canada, you could lose your license. So he was a heretic, and I went somewhat on the traditional route, became a clinical professor, and I'm going to just show you what I've been doing the last 33 years, and I hope you enjoy it. So when the patient comes into the office and they see the hygienist, how's the hygienist going to recognize these patients? So we recommend this very simple technique called the stop-bang questionnaire. So if you're not treating airway now in your practice, you may want to add this questionnaire in right when you go back on Monday. It's a very simple technique to identify these patients that are sitting in your chair. A lot of times, well, they're not going to come in and tell you they're an airway patient. You know, I say men are in denial. You can't trust the guy. He's not going to tell you he snores. It's his wife's problem. And women speak in code. So a woman's not going to come in and say, women don't snore, first of all. They purr, and you never ask a woman if she snores. So you're going to have to identify the problem by looking at the patient. And you know how to do that, the wear of the teeth, high, narrow palates, narrow nose, retrognathic jaws. And then we do a sleep test. And I think that you guys should be autonomous. We can discuss that later because based on state law, certain states don't allow the dentist to give out a sleep study, a home sleep test. Most states do. I think there are only 5 states that will give you a hard time. And then you'll decide what you want to do in terms of the treatment plan. And the goal is to transform the patient. I think the crucial missing link and the way to really identify these patients like what you do, and you're going to see a lot of the symptoms that we're treating like fatigue, when you get rid of toxins and you get rid of the oral pathogens with some of the liposomal formulas, detoxing, we talked about amalgam removal, you're going to see that you're going to eliminate these same things. So we look at reflux, fatigue, difficulty concentrating, insomnia, panic attacks. These are things that I never would have imagined even 5 years ago that I would be able to treat as a dentist. We're getting rid of about 50% of the patient's anxiety within about 2 weeks. We're able to alleviate panic attacks now. And it's basically because the patient's being strangled. They're being choked. They don't know when in the night someone's going to come in their room and choke them. But if you were going to get choked sometime during the night, you would probably be anxious too. So we're in effect taking the hands off the throat. The patient's not being choked. And then again, a lot of these women have cold hands and cold feet when we look at certain types of cases and we get into fibromyalgia, TMJ, and we're able to explain some of these symptoms that I've been looking at for 33 years. We're now able to give an explanation for what my father was seeing years ago. This is from Gilles Levy's book, and I think this is very interesting. This is the functions of sleep. This is why we sleep. Number 1, fatigue reversal. Number 1 complaint, unrefreshing sleep. I don't feel refreshed anymore. I don't feel like I did when I was a kid. I'd never wake up refreshed. Number 2, I love this term, biochemical refreshment. Biochemical refreshment. That's really synaptoblastic activity. This is what Dale Bredesen talks about when he talks about reversing dementia, reversing cognitive impairment, reversing Alzheimer's. Instead of synaptoclastic activity, where the synapses are being destroyed, we're actually able to grow new synapses at age 50, age 60, age 70. Immune function, very important. Memory, huge issue today. And just general psychological well-being. How do you feel? You have those ants, those automatic negative thoughts every morning. Are you anxious? Are you depressed? Are you just cranky? Are you irritable every day? I think we need volume. We'll try it again. Okay. This is from the Mayo Clinic.
When you breathe, air travels down your throat, through your windpipe, and into your lungs. The narrowest part of that pathway is in the back of your throat. When you're awake, muscles keep that pathway relatively wide open. But when you sleep, those muscles relax, allowing the opening to narrow. The air passing through this narrowed opening may cause the throat to vibrate. That causes snoring, which many people experience. But in some people, the throat closes so much that enough air can't get through to the lungs. When this happens, the brain sends an alarm to open the airway. Most often, this is associated with a brief arousal from sleep. The brain quickly reactivates the muscles that hold the throat open. Air gets through again, and the brain goes back to sleep. This disorder is called obstructive sleep apnea.
Gives you just a little idea of what's going on. And it also is going to be the answer to why the dentist and the dental team, and this is really team driven. This is not the dentist doing most of the work, which is kind of nice, that we are the best branch of medicine to be addressing this problem because 80% of the obstruction is behind the tongue, behind the maxilla and behind the mandible, in the area of the soft palate and the tongue. It's an area where we're working every day anyway. We might as well keep the airway open. So this is a diagram that I think When we talk about today, we talk Chris Shade, we talk about oxidative stress. If you're interested in oxidative stress, which I know you are, if you're interested in systemic inflammation, then really what apnea is two things. Apnea results in intermittent hypoxia. So either you have oxygen going up and down as you stop breathing, or you have disrupted sleep. That's really what apnea does. Does two things. Fragmented sleep, disturbed sleep, or intermittent drops in oxygen. That leads to the release of these inflammatory cytokines and really systemic inflammation. That's why we're able to get the changes that we're doing, because we're doing it on a systemic basis. So if you're using ozone, this is perfect because we're getting systemic oxygenation, if you will. We're getting decrease in systemic inflammation. We're getting improvement in oxidative stress. We're getting normalization of endothelial dysfunction. And the data is pretty robust on this. So the effect on cardiovascular disease, the effect is profound, even on sympathetic activation. So we're going to talk about that in a little bit. Why is sleep important? Well, the number one here for this group, we're going to say clearing the brain of toxins. And I bring you to Niedergard's work, who talked and identified at the University of Rochester, identified the glymphatic system, the means of clearing toxins from the brain, which occur through this glymphatic system, which only occurs when we get deep sleep, which does not occur when we have disrupted sleep or sleep apnea. We can go 3 weeks without food. We can survive without our teeth. We can go 3 days without water. We can go about 3 minutes without air. So of the pillars of health, diet, nutrition, exercise, breathing, good attitude, we're going to put airway right up there and breathing at the top. And you notice I always talk about airway because our airway is with us 24 hours a day. It's not just sleep. It's how we're functioning during the day. And it's the stresses that we're putting on our body during the day. And you know, if we fall asleep for 3 seconds at about 42 feet per second, we could be 130 feet off the road in a ditch with just by falling asleep for 3 seconds. As evidenced by these train wrecks that we've had outside of New York City, Spite and Dieval, people dying. You hear it every day. Howie Hinden, who's a member of this group and a longtime friend who also studied with my dad, he and I wrote a book for the public called GASP. We were very frustrated that the dental profession wasn't really picking up on this rapidly enough. I started this work in 1990, so about 27, 28 years. And 27 years ago, 90% of these patients were unidentified. Today, it's only 85%. We've only moved 5 percentage points in 27 years. So I wrote this book, Howie and I wrote this book for the public. We give it out to the patients, and I think you'll find it an interesting read. The companion book that's written by an ENT is this book called Sleep Interrupted. If you haven't read this book, it's going to be an answer to a lot of questions that you've had your entire career. And it's going to explain the chronic sinusitis. It's going to explain the tinnitus, the fullness of the ears, the ringing of the ears, and these chronic ENT type symptoms that are really related to what we do as dentists. Very fascinating read. And so we're here today because 80% of the obstruction is occurring where we're playing in our playing field. It's our home field. We have home field advantage. Because this oropharynx is an area that's usually affected, and even mild symptoms, and we're going to talk about in women, snoring, upper airway resistance, the things that we can treat the easiest can give profound symptoms. This is a problem of a crisis of epic proportions. If you look at the rates of obesity, if you look at ADD, if you look at where we're going to be with dementia, I put the brain as number one because we start off with sleep, airway, large tonsils, adenoids. We're going to talk about kids today that are born with smaller jaws, smaller than ever before. We get the prefrontal cortex being affected by lack of sleep. That leads to something we call ADD. The kid doesn't really have ADD. So 60% of kids that are on medication don't need to be on medication. And that's affecting the prefrontal cortex. As we get older, it affects the hippocampus, and we call that memory loss. Where'd I put the keys? What's your name? So we're talking about neurobehavioral and neurocognitive problems in kids. And we're talking about, as we get older, things like anxiety and depression, which can also start at age 4 and age 5. Dale Bredesen has written a book and talks about the RECODE protocol, where he's reversing these problems. Secondly is the heart, and we talk about the work of Bale and Deneen. And again, they're treating cardiovascular disease. They can't be successful without working with the dentist. And they stay flat out, and they come out very strongly and say, if you're not seeing a dentist that's looking at your pathogens, we're not going to be able to stop heart disease. And lastly, inflammation. So if you look at this lady's face, that's what it looks like over the course of about 9 months. That's what it looks like to get rid of inflammation. If you notice the circles under her eyes go away, the dentist sent her to me and he said, Michael, fix her TMJ and fix her airway, send her back to me and I'm going to restore her. And that's what we did. So it's no longer Joe the fat boy from Dickens. These are sometimes very thin women that are struck with airway problems, and certainly TMD. So we do this healthy mouth baseline, and you have a lot of you are doing this, so we're looking for these problems when the patient first comes in as a new patient. And again, if you want any of my slides, they're welcome. You're welcome to all of my slides. I think you have my slides, as a matter of fact. We like to say that the airway is team-driven. The assistants are going to do it. The hygienist is going to pick it up, and we call her the hygienist because she's really the core of the practice. She's spending 2 hours with the patient at least every year, and she's the one that really is interested in the health of the patient. The ninjas, or the dental assistants, they're giving out the home sleep test. They're doing the cone beam send. Camille's here. It's great to see you. Inserts, adjustments, and then the appointment coordinator and the treatment coordinator. And then we're really linking these airway symptoms to the whole body. And we'll talk about that right now. Now, I don't know if that's Donald Trump. It looks like him on the far right. Larry Rosenthal's his dentist, who we're in the city together, so maybe I'll be seeing him for sleep apnea. But what's happened is, as our brains have developed, our faces have become pushed in. As our brains have developed, the maxilla and the mandible have retracted. And even McNamara found that 82% of all maxillas are receded, retrognathic. So as opposed to our Neanderthal friends, there's a great book called Sapiens, they had big projecting faces. They didn't have sleep apnea. They didn't snore. They didn't have caries. Modern man, this is the disease of modern man, and it's gotten worse over the last 200 years. Why us? We're the only mammal that doesn't have a lock between the epiglottis, the soft palate, and the epiglottis. We have this vulnerable area behind the tongue because at about 6 months to 12 months of age, our epiglottis descends. When we're breastfeeding, initially, we have this lock here. And so what gave us the advantage over Neanderthal is that we could communicate. We could tell stories. We could tell tribal histories. We kept together. We could communicate. We could strategize. But that very advantage with speech acquisition led to this vulnerability, and that's why today we have so much sleep apnea, snoring. The other thing was that as we became more upright, our foramen magnum moved further forward. So the back of the airway is the neck or the spine, and the front of the airway is the tongue, and both things have come together over the last few thousand years. And so instead of seeing a primitive type maxilla, that's the maxilla that we see coming. That's the modern maxilla that many of our kids come in today. And there's a lot of you there in the audience that are doing orthodontics, which is great. This is what you see coming in. This was the primitive jaw, and this is the crowded, raveled type of jaw that we have coming in, and this is the patient that develops airway issues. What business are we in? What do we do? What do we do for a living? You guys are way beyond a traditional dentist. Well, I think we're in the transformation business. We're restoring lives. We're taking care of problems that other people are not. We're preventing heart attacks. We're preventing strokes and dementia. This is some of the risk factors that we're going to see. And these are the kids. This is an article by Christian Guilleminault about death in the nasomaxillary complex. These children all died. There were 6 kids in the study. They all died before age 5. They all had high narrow palates, mandibular retrusion, enlarged tonsils and adenoids, deviated septum, small upper airway, and an insufficiency of the nasomaxillary complex. And this is what we see very often today. We still see this today. This is a study by Karen Bonnick. And Karen Bonnick, David Gazal, there's a whole group of PhDs and pediatric sleep specialists. Karen Bonnick looked at 11,000 kids over 6 years and found that the kids that had mouth breathing, snoring, and sleep apnea had a 20 to 60% increase in ADD. Not just ADD, but behavioral difficulties, anxiety, depression, peer-to-peer issues, conduct issues, aggressivity, rule breaking, and impaired executive function. By age 7, that was up to 40 to 100% increase. Just with mouth breathing, snoring, and sleep apnea. So we kind of changed the paradigm. We said, if you're going to treat these kids, don't go in when all the teeth, the permanent teeth are in. Don't go in at age 8, 9, 10, 11. You've got to go in at 3, 3.5. So Kevin Boyd talks about less than 5. I want the kids to be mainstream by the time they get into kindergarten, which means that orthodontics is all about brain development. Orthodontics is about having the kids be able to breathe, along with taking out tonsils and adenoids, along with treating allergies. It's about brain development. The brain's not going to develop unless it's getting oxygen. If the child's not breathing well, if the child's waking up all the time, if the child's always congested, the prefrontal cortex will not develop ideally. And we're going to label it oppositional defiant disorder, ADD. What the kid really has very often is a sleep disorder. So Bill Hang and I wrote an article called Airway Centric Orthodontics. You might like to refer to something as airway friendly orthodontists, but that's the type of orthodontist that we're looking for you to see. These are some of the red flags. You have the slides. Large tongue, scallop tongue, high narrow palate, long face, gummy smile, a large malampati. You got to remember that when you go back to work Monday, 50% of the patients in the hygiene schedule have airway, sleep, and breathing issues. Now, are we going to choose to identify? We're just asking you to be aware. We want you to take the airway pledge, and we want you to commit that you're going to at least identify. You don't have to treat it, but then refer it elsewhere. 50% of your patients snore, 85% are undiagnosed, 36% have sleep apnea, and this affects infants, kids, it affects everybody. And why should you do it? Because we are the profession. We are the best profession. Better than ENT, better than pulmonologists. We're in the best position to do something about this. Now, what we see in our practice, number one complaint is fatigue, unrefreshing sleep. We also have a big pain practice. They're exhausted. They have difficulty concentrating. They could be irritable, depressed, anxious. They have reflux. How many of your patients are on medications for reflux? Morning headache, high blood pressure. Airway-centric dentistry and the role of cardiovascular. So if you don't know about Bale and Deneen, physician, general physician, and a nurse practitioner, and they're saying basically we cannot get rid of cardiovascular disease without you guys treating the high-risk pathogens, oral DNA, Haynes testing, oral vital testing, and everything that you're doing, as well as treating the airway. And they talk about root cause. And some of the root causes here, periodontal disease, endodontic disease, and obstructive sleep apnea. This is a sample of an oral DNA test. Now we realize that I stopped doing dentistry 10 years ago, tooth dentistry. But I realized I was putting an appliance in potentially a dirty mouth. How could I do that? How could I say I'm getting rid of inflammation and I'm not looking at oral pathogens? So now we're starting to look at oral pathogens on every case, in every patient, because we can measure it and we can do something about it. Now, I think we need to go a step further. I think that we need to take inflammatory markers, and you can do the blood draw yourself, you can send it out to a Quest, Cleveland Heart Lab. But I think what I'm looking to do now is I'm looking to take these blood levels at the beginning of treatment, working with a physician, and then take these blood levels at the conclusion of treatment and make sure I really am walking the walk, that I'm really getting these inflammatory blood markers to be normalized, as well as all other blood tests that you could order. This is just showing that L-Plaque2 can be managed with something like PerioProtect. I take a cone beam on every patient, because the cone beam gives me a picture of the airway. And I don't have to be too bright. I can look at this, I can show this to the patient. The patient says, that explains why I'm winded after I walk up a flight of steps. Does this explain the problem I've really had most of my life? And then they're very motivated to go ahead. We're also doing ENT evaluation. We looked at deviated septum, we look at turbinate size, but we're getting this information and we're quantifying it on every case. I started with the 15 by 15. I have an ICAT. I've had 2 Newtome units, and now I'm using Vatek. And now I have the big unit, and now I'm getting down to C6, C7, T1, first rib. And it's really, I work with physical therapists. I have fellows coming into my office, but most of my TMJ patients also see a physical therapist. Probably about 75%. And again, we can quantify, we're getting a number when we quantify that airway, the smallest area. Of course, we still look at TMJ. We talk about the Gelb 47, which I'll show you in a second, but these joints are compressed. This is decreased joint space. But what we found is that airway trumps everything else in dentistry. And when I talk to my friends, and we used to fight, my father would fight with Pete Dawson. Everyone in dentistry was shoving the jaw up and back. We were bringing the jaw down and forward. And now we agree that airway, when I talk to my friends like Mark Murphy from Pankey, Whit Wilkerson from Dawson and AOSH, we now agree that airway trumps everything else in dentistry. Airway trumps everything else in dentistry, which means if you're looking to restore teeth, you have to start with the airway. It's not the other way around. All cardiovascular prevention programs must include an oral systemic component, a lot of what you do, and an airway component. If you haven't read this book by Dale Bredesen about preventing dementia, reversing dementia, I strongly encourage you, if you have family members, I strongly encourage you to read this book and then study the protocol. Bredesen talks about a roof with 36 holes. That's why there's never been a medication to date that's been able to manage Alzheimer's. The perfect drug would have to do all of these things. It's lifestyle. It's really about inflammation, because the most common form of Alzheimer's is type 1, which is inflammatory. Now, type 3 is what, in this academy, we treat a lot of toxins and we treat infections, and we're great at it. And that's very important. That's type 3 Alzheimer's. Type 2 has to do with trophic factors and is the thyroid, the estrogen, testosterone. So I put mercury, mold, very big mold issue. Chris talked about that today. Mercury, and of course the pathogens that we find P. gingivalis now in the brains of Alzheimer's, treponema in the brains. So really, you have two phenotypes. When you stop breathing, you go to bed, you have inadequate anatomy. We already said that our anatomy is getting smaller. You have inadequate anatomy. Go to bed, you have the dilators, the genioglossus is working extra hard. You go to sleep, you lose this protective reflex, your airway collapses. You have a respiratory effort because you want to breathe, and it's either going to go neurocognitive or it's going to go cardiovascular. Those are 2 general phenotypes. It's either going to affect the brain or it's going to affect the heart. UCLA found that the blood-brain barrier becomes more porous when you don't sleep well. the infections and toxins then are let into the brain, are allowed to go through the blood-brain barrier with poor sleep. This is very important. If you've been making a night guard, like I was taught when I graduated Columbia, if you went to any dental school in the United States in the last 30 years and you were taught to make a night guard, there's a good chance that that night guard is closing the airway. So let me say that again. If you're making a flat plane night guard, like we've all been taught to make, cuspid guidance, posterior disclusion, anterior guidance, there's at least a 50% chance, and I say 90% chance that that appliance is closing the airway, worsening apnea and worsening snoring. So the American College of Prosthodontics, very conservative organization, came out last year, practitioners should screen patients for apnea prior to fabricating a night guard, because there's a good chance that the airway and breathing and sleep has something to do with the clenching. They put the word liability in there. This is where periodontal disease was 25 years ago. There will be lawsuits. Dentists will not listen to this. Dentists will close the airway. And this is like a Harvey Weinstein moment. After you've heard this lecture, I'm really sorry. This is like ruining your lives potentially, but really improving your patients' lives. It's no longer acceptable to close the airway. You took a Hippocratic oath, and I know I'm talking to the wrong group, but you can't keep closing the airway. You can't keep putting night guards in that may. Now, if you don't know, that's just as bad. So you have to know whether it's opening the airway or closing the airway. The American Dental Association. We've had our issues with the American Dental Association. They came out with a good statement saying that dentists should screen and refer for diagnosis for airway problems. Thank God. It was a great time that they did that. Now, because the ADA said that, the 5 states that tell you that it's a felony to order a sleep test, we're hoping they're going to reverse that position within the next year, because the ADA is now asking us to screen for this, which is great. The problem starts in childhood. Growth and development changes when we can't breathe through our noses. When we're mouth breathers, like I was, it alters the shape of your face when you grow. It alters the development of your brain. So you should start young, according to the ADA. I totally agree with that. And oral appliance therapy, you can't read that as effective for mild and moderate apnea. And then follow-up sleep testing, they're saying it has to be ordered by a physician. That's really not the way it works in everyday practice. I'm sorry. We do follow-up sleep testing on almost all of our patients because we want to make sure that the treatment that we rendered was efficacious. My brand promise, my criteria for success, when I make a night guard, I want my night guard to get rid of fatigue. Everyone else is like, we're going to make sure those laminates don't break. We're going to protect the dentistry. No. We should be able to make fatigue better. And if we can't do it with this, then we're going to look at the toxins. We're going to look at the work of this academy, because that's the other side. And if we need to work with a functional medicine, integrative medicine physician, so be it. I don't want the patient to have a headache when they wake up, no neck pain, better memory, improved focus and concentration. That's my expectation now. I've raised the game. I've raised the bar, and I expect this of myself. Less anxiety, wake up feeling refreshed, no reflux, psychological well-being. That's what we're doing today as dentists. So the stop bang. We make something called the ACG. You know, my father would go to fatigue conferences, Richard. You'll remember this, Dr. Cole. And he would say, I'm getting rid of the fatigue because I'm fixing the TMJ. Because he was moving the jaw down and forward, he was opening the airway at the same time. And by bringing the jaw down and forward and holding the tongue down and forward, he was opening the airway and didn't even realize that that's what he was doing, alleviating fatigue. And he was doing it during the day too, which balance we know from Jeff Hinden. Jeff Hinden spoke here last year. Jeff talked about the balance between the sympathetic and parasympathetics. When you put an appliance in, when you raise vertical, when you open the airway, the body likes that. The body likes oxygen. And so what happens is the heart rate variability improves. That's the day. So maybe all the TMJ work we were doing, maybe it was working because we were opening the airway as much as we were decompressing joints and lengthening muscles. So this is the ACG Airway Centric Guided Day Appliance. It opens the airway during the day because daytime appliance used to be used for dentists for headaches, clicking, pain, clenching, to stabilize the neck, earaches, tinnitus, and ear fullness. What if, though, we could improve heart rate variability? What if we could decrease fatigue, improve energy, balance parasympathetics, improve anxiety, improve depression, lower blood pressure, improve neurocognitive, and improve mood? This is a paper from Avram Gold, who writes about functional somatic. This was a turning point, another turning point in my career, because I realized that these women that were coming in, these women were thin, they were tiny, they were fit, and they were exhausted. These are the women that would come in, my failures. They were still clenching. Their jaws were sore in the morning. These women have cold hands and cold feet. Going back, sorry about this slide. Taking the bite for the ACG. How do you take a daytime bite? And I'll get back to the women. Well, most people want the chin in the middle of their face. No clicking. We use phonetics. It's a Gelb 4-7 position. Sorry. It's a Gelb 4-7 position. Facial aesthetics are improved, which you're going to see. It opens the airway. It can give anterior guidance and canine guidance. These are the thin women. There's an article that was written by one of my patients in Elle magazine, which you should get, May 2017, An Awaking Nightmare. These are women that are, you know sleep apnea is mostly men. UARS, upper airway resistance syndrome, affects mostly women. It says 1-to-1 here. These women wake up exhausted. They have something that we used to call fibromyalgia. All their muscles hurt. Basically, the brain is sensitized. It's an upregulation of the sympathetic nervous system. The brain is sensitized. Fit woman, thin, her neck always hurts. I never put this together until 6 months ago. You know all these dizziness, the lightheaded patients that come in, they're dizzy, they're lightheaded. And we used to think it was the sternocleidomastoid muscles. What I finally realized was that lightheadedness was part of this upper airway resistance syndrome. Dizziness, low blood pressure, not high blood pressure, not like the men have high. These women have low blood pressure, orthostatic intolerance, and they're chronically tired. So URS becomes an explanation. If you knew you were going to get choked, why would you go back to sleep? If you knew that you were going to get choked during the night, I wouldn't want to go back to sleep. I'm going to get more oxygen if I stay up. That's called insomnia. Dr. Krakow has a great TED Talk on that. These women have headaches. We always thought it was TMJ related. They're depressed. They have reflux, runny nose, hypothyroid, low blood pressure, migraine, irritable bowel. So if the sensitization affects the stomach, it's called irritable bowel. It affects the nervous system. We call it chronic fatigue. Now, of course, we know about the toxins, and you guys are going to do your work, but if the patient's not responding, why not look at the airway? Why not look at something like this, which can come from just a narrowed nose? Sometimes women have had rhinoplasties. Sometimes men have had rhinoplasties. Sometimes the nose was the proper size, but when we shrunk it, when we did the rhinoplasty, the patient can't breathe. Or they have a deviated septum. Or they have a narrow palate, okay, like my friend I was talking to last night. Narrow palate, never got palatal expansion or not enough palatal expansion. And what is the roof of the palate? It's the floor of the nose. So you can never, it's like having a 500 square foot apartment in the East Village. If you take out all the furniture, your kid's still living in a 500 square foot apartment. I don't care what you do to that nose. It's really going to be tough to be able to breathe through that nose. And that can lead to this thing called upper airway resistance. Airway resistance, upper airway resistance. Doesn't have to be snoring. It doesn't have to be apnea. That's what it looks like to have a narrowed external nasal valve. But a lot of these women have a narrowed internal nasal valve, and we're finding out who the ENTs are in our community that get this. It'll be about 20% of the ENTs may get this. We have something called mutes, and there's a company out there called XClear. Julie's here today. Nasal spray, xylitol spray, 3 times a day. Talk to Julie. We also recommend nose cones or these mute nasal stents. You can give it to the patient. We give it out to every patient that has a narrowed nose, because that can be the difference for the dentist between success and failure. It's not enough just to bring the tongue forward. It's not just enough to bring the jaw down and forward into open vertical. So we talked about this. So this talks about URS being this limbic system, it gets sensitized by mild pharyngeal collapse. The limbic system, which then relates to the hypothalamic pituitary adrenal axis. And it's basically a stress to the system, and it's an imbalance. It's an upregulation of the nervous system. Everything gets sensitized. This is a study that Paul Miller did just by expanding the palate. This is in a adolescent, was able to get rid of treatment-resistant depression just by allowing the kid to breathe. Expand the palate in an adolescent, open up the nose, improve nasal breathing, better sleep, better function. So we came up with this appliance for women called the HERS, because every appliance that we tried, and we tried every appliance out there, the women hated it. It was too bulky. It was cutting into the sides. And these women have narrow palates. They have narrow faces. They needed an appliance that was good for women. So we designed something. There was nothing covering the linguals of the upper molars. There's no acrylic. And this is milled out of a puck of polymethyl methacrylate. It's a non-porous material. Bacteria doesn't grow on this like other products, like other porous, like other soft liners. So this is an appliance that's not going to smell after 6 months. It's not going to smell after a year, which is a big thing with these oral appliances. It also has rods on the side that are much smaller. Now, the problem is the men all want this appliance now. So we don't say we want a HERS, we say we're going to do a Perform for the gentleman, because he wants to be able to keep a lip seal at night, right? He may tape his mouth at night, but he wants to be able to get his lips closed, so the men are now asking for this appliance. This shows us that this is a sensitization that affects everything from interstitial cystitis to endometriosis to vulvodynia, pelvic floor dysfunction, and it's a sensitization of all these body parts. It could be present as migraine headache. It could present as tension headache, fibromyalgia, all these things that we've struggled with over the years. All my failures, not all my failures, but I'm answering a lot of my failures with recognizing that this can occur. How do we get from here to here? You guys get these same results, but I don't know a half of what you know, a tenth of what you know. And I'm able to achieve some of these results by a recipe. It's an old New York formula, maybe from North Carolina. Little oxygen and a little deep sleep. A little more deep sleep, a little bit more oxygen, and you can open the eyes and restore the face. Look at the difference in the skin tone. And that's what she looked like after the dentist restored the case. And we're struggling with this. We're talking to Dawson. We're talking to Whit Wilkerson about this. How are we going to finish these cases? Do they need to be finished? And it's a good discussion. Watch the transition of the face over 3 months. When we give someone back vertical, when we open their airway, we transform the face. We're in New York. We're such high pressure. We're clenching all day. Our teeth are touching all the time. And our masseters get wider and wider. Our lips get thinner and thinner. And what do you come in with? Headache, neck ache, ear pain. But we make them an airway appliance at night. Look at her. 4 by extraction, narrowed airway. Look how beautiful she is. She comes in, and the photo got corrupted because we got hacked. But look at how she starts out. Still an attractive woman, thin lips, wide masseters, migraine headaches. reduced joint space. She's chipping the teeth. And in just 3 months, by giving her some oxygen, bless you, giving her oxygen, giving her some vertical, she gets her lips back, her eyes open up, she's vibrant, and that's what it looks like to fix oxidative stress and lower systemic inflammation. That's the picture of health to me. This woman comes in haggard, she's tired, she's an interior designer, she works half the time in Miami, half the time in New York City. She's had 2 rounds of bad orthodontics, and in 3 months, she regains what she was, maybe better than she ever was. And who's the best profession? The dental profession. The dental team is really the only ones, the only profession, the only branch of medicine that can deal with this. And we talked Dr. Cole, Al Fonda, Harold Gelb, the dental physician. We're the physician of the oral region. That's what we are. That's our specialty. And we take cone beams on everyone. We can show you the morph. And it takes about 3-4 months for these metabolic changes to occur, and that's what they look like. And you can see, look at the abfractions. And what does the dentist do? He puts composite on it. The dentist doesn't know what to do with these cases. The dentist is lost. But it's not very complicated. Anyone can get these results. Aging face. Aging face. That's what we're able to do when we treat the airway, when we treat the problem during the day and we treat the problem at night, we're able to get these kinds of results. That's called an ACG functional or Juvabite. It's called Juvabite because it's anatomic. The patient can chew with it. And if you choose to, you can go to the next phase. We also do hair in our office in the back. We do coloring. If you want to know some of my secrets. And the fur doesn't hurt, so that's fake fur. And look at the difference. When you understand and you learn to recognize what these patients look like, they all have decreased vertical, the lower third of face height. But Richard, in the past where we thought TMJ, 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 today I think airway, 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 oxidative stress, endothelial dysfunction, systemic inflammation. Because how do I get these changes? How do I get the eyes opening up? And the literature is just full of documented evidence about the role of airway in cardiovascular disease and everything I'm talking about. Endothelial dysfunction. I own the first EndoPad. I was measuring endothelial dysfunction about 10, 12 years ago. And we can do it, you can see it laterally. She will not model now without something in her mouth, one of our appliances. We also can take young women that have these big masseters, and we do use Botox. You can use PRP, you can use Botox, but we're able to use Botox, and we're able to get that narrowing of the masseters and a relaxation of the masseters. I'll show you one case. Loud snoring, excessive daytime sleepiness, suboccipital headaches. Did a CBCT. That's the type of airways that you see coming in today in 2018. Those are the airways that are out there. If you will image these cases, the patients have no airways. Now, she happened to have been a 4 bicuspid case. I know we have a couple of orthodontists in the audience. I know it's controversial for some, but you just can't make that box smaller. We already have been, our faces are shrinking. We need to make them even bigger, okay? Our faces are shrinking. Our kid's face, there's not room in the mouth usually for all 32 teeth. And all you have to do is go to Smithsonian Institute, go to Natural History, read the book Sapiens, read Lieberman's work from Harvard, and you'll understand that one of the consequences of our epigenetics, and it really is epigenetics, is causing these changes. We do a sleep test. Now, when we do a sleep test, we look at the apnea, the hypopnea, and the index, how many times they stop breathing per hour. This woman was stopping breathing 69.3 times an hour. Her oxygen was going down. Remember the hypoxia, which you guys are looking at, which we all care about? Her oxygen was going down 66.2 times an hour. We put in an appliance during the day, sympathetics, parasympathetics, heart rate variability, TMJ, headaches, and we put a ProSomnus appliance in at night. That's her during the day. Look at that occlusion. And we were able to get her down to 12.2 and 8. Now, what I didn't tell you, what I didn't show you, she desaturated like 300 times. She desaturated an incredible amount of time, which I will have to show you afterwards. So that's a pretty good result. So we want to document. We're able to physiologically monitor what we're doing. This thing called generalized anxiety disorder, it sounds to me like it's a sleep disorder. This is the criteria. You need 3 out of 5 to have GAD, generalized anxiety disorder, restlessness or being keyed up on edge, being easily fatigued, sounds like a sleep problem, difficulty concentrating, irritability, muscle tension, and sleep disturbance. So that's why we're able to get rid of 50% of anxiety, GAD, within 2 weeks. It doesn't seem that complicated. We use a George gauge to take a bite. I'm happy to go over with anybody these techniques. We're going to be teaching, and we take a bite. We scan the bite. We use a Trios, an iTero. We scan the bite. We send it digitally. It's a digital workflow. It's very easy. It's very clean. We do an Epworth. We do a stop bang. We want to ask you, if you will take the Airway Pledge, you will go on our website for free. If you will go to airwayhealth.org, it's my foundation with Howie Hinden, a member of this academy. If you will just go into airwayhealth.org and say, I pledge not to close the airway. That's all you have to do. I believe in an open airway. I believe in apple pie. Then your name will go on the website. We need people like you in your areas geographically across the United States because patients are looking for people like you. So please sign the Airway Pledge. My website, if you want my slides and you don't have them, drmichaelgelb.com. And M. Gelb at Gelb Center, my daughter Marissa G. at Gelb Center, E. Dumay at Gelb Center. And if you want more in depth, we're giving a university-based course for 6 days, 2, 2, and 2, 2 days in July, 2 days in August, 2 days in September. And you're welcome. And, thanks to my dad for, I really stood on his shoulders, hopefully. And we've moved into the area of Airway Centric from what was a great beginning with TMJ. And I want to thank all of you for the great work that you do. Thank you.